So, guys, I want to spend about 20 minutes, I think, with this panel. As I mentioned before, I've got some prepared questions, but I suspect there's people in the audience that probably have questions as well. I'd love to start with the audience, if there are questions. If not, then I can move in. The gentleman right here in the short sleeve shirt.
Yeah, I'd like to ask Ben a question about what you're trying to do, because there's a culture clash between what you're doing and how it's going to be navigated. Because in some respects, a C corporation, if it's working well, you're going to be saving money for the system. And how will you benefit, or how will that work out? I mean, in some respect, you get the traditional integrated system, which is really top down. You're on the side being bottom up. And how do you see that shifting over time? I've got so many more questions, but I just wanted to give you an opportunity to talk and anticipate what the challenges are going to be.
Sure. So back on, great. It's a great question. I don't have a clear answer at this point. I'm very comfortable living in a fog, and probably have to be for some time related to this. So, I mean, the big question is, well, why in the world are they letting you do direct primary care in 5-10 years? If you do it really well, you're going to lose the money. The system will make less money. That's kind of the great paradox, the great question. The best response I've heard to that is that, hey, listen, as a system, if we look the same in 5 or 10 years, then yeah, you're probably right. But we're going to have to change. Value's coming, drive towards the consumer is coming. And so our current business model is not sustainable as it exists, and it's going to have to change. And so associated with that, a primary care system that's basically willing to lose money in order to generate the referral base is also not a sustainable part. And so this, to them, seems to be an opportunity to really kind of see this idea of something that potentially could be a better fit across the board. But I will say that we have 10-year trajectories that financially and otherwise look really, really good. But the pressure is high enough in the short term with really high expectations that if we don't meet those, then we won't even have a chance to show that in the long run. So even though the system is committed to primary care, it's really hard to get everybody to think in that long-term capacity and get away from the short-term margins. So we'll see. I'm kind of rambling a bit, but I don't know if that starts to answer the question. We can take it offline. Okay.
This actually sort of ties into the Trojan horse question. What happens when direct primary care is there is usually that it's invisible what we're doing. I mean, I haven't sent a bill to an insurance company since 1997. They haven't sent me a letter to thank me for that. I have dramatically reduced the amount of use of specialists and hospitals. I mean, Q-Alliance has had enormous amounts of data on this stuff. We were getting roughly a 30% reduction in spend across the board. But nobody was feeling it. So it was invisible. The only thing that would happen as direct primary care begins to grow is that you don't need to hire that extra specialist. You may not necessarily need to put a wing on your hospital. There are some things that the rest of the healthcare system could adjust to, which would actually make them in the business of healthcare again, which a lot of them would like to do. They would love to be on this mission with us. The problem is they're afraid of it. And so if you walk in to pitch them on a direct primary care group for your hospital, and we did that at Q-Alliance. I was there for one of these hospital things. They love it. They love it. They've got the heaviest utilizers of any employed group is hospital employees. And they were thinking, oh my God, we could save millions and millions and millions of dollars. What a great thing. Oh my God, what happened if everybody did this? And that would be the end of the conversation. So the fact that they found somebody who's willing to even do this experiment is impressive to me. And I think they'll find out it's not as painful as they think.
Questions from the audience?
A couple of questions from Ben. So presumably your system has its own primary care branch, and they are presumably have some sort of quota of number of patients a day they're supposed to see. How is your quota get How's the salary of a physician in your C Corp different than the salary of a physician in the larger overall corporation? And has that gone public yet? And are you catching heat from other docs about that?
Good question. So I'm the first physician that the system has ever hired that has zero volume component to my contract. And I'm very appreciative of my direct boss, who's also a physician, for making sure that that was the case. That was really designed. People pushed against him in that way, but he said that in order to give them the space to do this in the right way, there can't be any volume component. So I am distinct from all of the other primary care practices in that way, primary care physicians. I do have quality metrics that are tied to my contract, and those look exactly the same as the other physicians. So there, for example, there's a large ACO that's part of our health system. It's one of the largest in the country. And there's really no incentive. The director of the ACO says, hey, listen, there's no incentive for you to join this ACO, but we are operating kind of on a day-to-day basis as if we're a part of it. So in terms of all the measurements in that industrial complex, we're living within that, mainly as a way to try with data to prove that what we're doing is different and better than the other primary care practices within the system. So that piece is tied to my salary.
Gentleman in the back.
How are you guys, when you go to employers or groups, how are you managing the value proposition to them to say, hey, we are, to Dr. Bliss's point, we're saving 30%, but oh, by the way, here's the data, and can we actually do it? Here's the proof. How are you managing that and addressing that?
Well, it really is where I think the data comes into play. And once again, because remember, you're asking the employer to spend more money up front. They're already purchasing insurance for their patients, right? But the problem is we have completely priced the middle class out of healthcare. Deductibles in businesses have gone from $1,000 to $2,000 to $3,000. Not uncommon today to see $5,000 and $6,000, right? And the middle class can't afford that, so they're choosing not to get health care. And it's, once again, we're having that data to be able to now show the employer that, listen, we're going to get you health care. That's what you're purchasing. Today, what you purchase is nothing. You have to have insurance, right? And we are big proponents of that. We have to have it. But what we have to do is show that when you bring direct primary care in with an insurance policy, you're going to get to save money. And that's really where the data comes in. The employers are there. They believe. They want to see the data. And it's, once again, this data I shared with you, the one-year data, just became available to me within the past month. So we're very excited now about going out with one-year data. I'd mentioned the problem of one-year data is I no longer have a control group because 100% of Burton employees are now Strata patients. So we don't have that control group to follow at year 2. But we have more companies we're converting. We're going to have the state's data pretty soon, I hope. That LB 1119 will start in July of 2019 is when we start taking care of patients.
Joe, I've got another question for you here, and this is certainly it's representing a lot of our DPC client base today. Totally understand and appreciate the importance of data. One of the main reasons that that physicians are moving into direct primary care is to get out from, what was Zubin's term, the digital the reporting medical industrial complex. And the concept of working with Strata as a physician, being beholden to all the reporting standards and the work they need to do, feels like it's just bringing me right back into where I wanted to leave. I'd love your perspective on how that balance could actually manifest itself for that.
That's a great question, and in all actuality, that's the beauty of KPI Ninja. So when you get to meet with Noreen and Beneath, what they have done for us as providers is we're not doing anything special. We're just taking great care of people like all of you do in the room, and the data is then there, and they write the analytics to go get it. So we have to be asking the questions right from the beginning. And then what we've done with Strata is we say every patient every year has to get a set panel of labs done. And then he's got a distinct way to go get all the cost data for us because it just so happens that KPI Analytics also is in charge of knee high for the state. So they have all of that data. I can't even remember what Vineeth tells me. I mean, 2 million lives that they're following for data. So when we go look at the N we have for comparison, it's rich and robust. But you're absolutely right, Mike. What we're not asking people to do is do something special in a claim, fill out certain paperwork on people. We're not doing any of that. All we're doing is asking you to take great care of your patients and make sure that we get this set of lab every year. And as a part of that, then, we cover that in our cost. So Strata Healthcare pays for those annual labs. We're not asking the patients to do that. So that's very helpful then when it comes to the data, because the patients aren't being asked to output any money for that robust set of labs. When I talk robust, I am doing the same set of labs on every Strata patient every year that I do on my own concierge patients that are paying me $5,000 a year. So we're following HSCRPs, fasting glucose, hemoglobin A1Cs, all the lipids, those kinds of things to document where we're going year after year.
Young lady in the back, and bike over here, guys, be helpful. Yeah. Great.
Dr. Eric Kroll, founder, Tampa Bay Direct Care Network. This question is for Joel also. How do you document to the employer their savings in adding DPC from preventing unnecessary care? Because my biggest struggle is they believe their broker's already controlling the spend.
Man, you have nailed it. You have nailed it. And you're right. And I got to tell you, it's the toughest part to nail. Am I right, Noreen? It's one of the toughest bits for us to go get. But what we've really been hammering on Spruce to help us with is help us go back and look at this data and find these key communications where the patient brought up, do I need to go to the ER? And they didn't have to go because we communicated. Or that, do I need this scan done? What did it cost? All those kinds of things, so that we can go and look at our Spruce communications to document the ER visits that didn't occur also. Not just that we're decreasing the total number, but to truly show that these are ER visits that didn't take place because they were able to communicate with their primary care provider. So that's all data we are gathering that we can then share with businesses and the community.
First of all, thank you all for all your hard work. One of my questions has to do with the public perception of the importance of primary care. So we all think it's great. We're trying to provide it. We're trying to work the business system, the insurance system. Insurance companies understand, some of them, that it reduces costs. But as a culture in America today, most people have lost that feeling of needing a primary care physician. I don't need a primary care physician. I just go to the Minute Clinic. I know what's wrong with me. I call up the specialist. Have any of you given any thought to how we can change that perception of the importance and value of primary care in the ordinary person's mind?
Esteemed panelists, who wants to jump in?
Well, I think about that every day, and I lie awake at night thinking about it, because it is a branding problem. And some of it is regional. In rural parts of our nation, if there's a family physician in a small town, that may not be as big of an issue. They may have some sustainability problems. In a large metropolitan area like New York City or New Jersey, family medicine is getting clobbered. They're getting clobbered because they're having a difficult time representing their value. But I think a lot of that is because so many family physicians are still being puppeteered by this system that Zubin spoke to us about earlier. And so how do we change that and flip it on its head? The American Academy of Family Physicians put some money into some branding initiatives, but building awareness campaigns is expensive. And just telling people that we're needed doesn't work, as you've suggested. What works are programs like we're seeing here and like Joel's doing, where people learn over time that, oh, that's what I want. They will vote with their pocketbook. And so over time, this is why I feel, and I'm on the board of the AFP, that the DPC is so critically important to bending the healthcare cost curve. But consumers are not going to come until they have to make the value choice, until it comes to the spend. And you're absolutely right.
One of the points that I like to make is that there's a reason why DPC outperforms primary care in most other forms. And part of that is that nobody believed us at the beginning. Trust me, nobody believed me. I was the first guy who made the value proposition to my patients. So we had no idea who was coming to the party when we decided to transfer. And it's hard to explain it to people. The way this actually happens is that when people are faced with a market problem, if no one understands what the value is, then we get busy and give them value. We create value. This is the most innovative thing going on in the United States right now in terms of patient care. This is it. And every patient who comes to one of these practices becomes the messenger for the rest of the world. And you have to treat them like that. This is not, it's not automatic. You know, people are so used to hearing claims that don't actually go anywhere from everybody who talks about everything. And so they don't believe anything you say. But one person who comes out of your practice and tells 25 of their friends is the reason this thing's growing. And we're hitting, you know, what geometric progressions hit. And that's going to start happening faster and faster and faster now. So this will not be a secret very much longer. So I wouldn't lose hope because you run into these barriers. I've been bouncing off barriers and I've been mowed down. I was killed by Medicaid. Believe me, I know everything that can happen to you. But in the end, this thing wins because it does work. Because great care is a function of an interpersonal relationship which we own. And if we don't get too greedy, if we don't try to get too many patients in our practice so we can make lots of money, if we make sure we're providing the real thing, then this movement's going to keep growing like crazy. So I wouldn't lose heart.
Just take 1 minute to give some thought on that. So I think in the next 10 years, millennials are going to be the largest percentage of the workforce. And what we seem to know about millennials in terms of what they want is they want access and they want something at a very fair cost. So our approach is that if we can do that, but provide an exceptional experience and get them into the door, then exactly what Garrison is talking about will start to happen. So we have half of our population is an employer population, the majority of which are service workers, restaurant workers, majority of which are young millennials. And the light bulb effect has happened for pretty much every one of them when they've come in the door. They've sat down with me. We've had 60 to 90 minutes to get to know each other, to hear their story, and to provide care in a way that really they had no idea was possible. And so the more of them we're able to actually get in the door by making sure that we do the access and the cost really well, then they get to see that there's really value in that experience, and then it starts to expand from there. So that would be my thought on it. And I realized I actually didn't answer the second part of your question, which was, what about the rest of the physicians in the system? And so I'll just quickly say that I've tried to be somewhat strategic there, so it's not public that I'm the first physician in the system that doesn't have a volume component. And mainly what I've been doing is having targeted conversations with different colleagues to let them know what we're up to. And the reaction has been, you know, frankly, like on one end, why in the hell are you doing this? I've been practicing for 15 years. You're a year out of residency. And why the heck did they hire you? And really kind of a jaded response to some people saying, well, man, I'm glad I'm not doing that, but you figure it out and I'm ready as soon as you're successful. And so I'll have to continue to navigate that. But there's definitely a lot of upset physicians, and so we're trying to strike that balance of really letting everybody know what we're up to, but not just being the easy target for darts.
We're going to take one more question before lunch, or two. We'll do two.
Thanks. My name is Jordan Schlane. I'm with a group called Private Medical. I want to make a comment, is how do we take back primary care and medicine in general? And I think if we get a little bit philosophical, it goes down to language and the language we use and how we talk about medicine in general. And, you know, as I've been doing this now for 20 years, I realized we're called providers. And I went to go look at my medical degree from Georgetown, and it wasn't an MP, it was an MD. And so why are we called providers if we're doctors, number one? And it's because the industry wants to dumb us down into something that's not what we are. And so, like, I think we have to stop using the word provider. I mean, nurses are, we use provider as a general term, but if we're referring to ourselves or our practices and we're doctors, we should reclaim that. The second thing is, the last time I checked, the word reimbursement, if you look it up in the dictionary, means I gave you some money and I actually wanted it back, right? So I go to Whole Foods, I don't reimburse them for the food that they bought. I go to the gas station, I don't reimburse them for the gas that I bought. I pay them. And so one of the interesting things, and we all use the word reimbursement, is we're not actually being reimbursed, we're being paid. And when a patient hears that the doctor didn't get reimbursed, or some third-party business person hears that the doctor didn't get reimbursed, like, well, the doctor's an idiot. He probably got in a bad deal. He shouldn't have given the guy the money in the first place, right? But the truth is that when someone hears that the doctor didn't get paid, or when somebody didn't get paid, then that's wrong. Something's wrong with that. So I think, you know, and I can go on and on about the words that I just can't stand in medicine, but I think if we want to kind of reclaim our own agency in this field and not let other people take it, it is language, and it's simple as that. Thank you.
That was profound.
Was there one other question back there, Santi? Yes, please.
Michael.
So we had this interesting challenge of, you know, if we're part of the hospital system, how do we maintain our autonomy and our referral patterns and work within our market, because we have 3 or 4 major systems in our market. How do we maintain our autonomy and change the market, not just the one system, right? Because we're kind of salt in that market, like we're really facilitating change through our leadership. And so we chose not to take that, which it would have created an opportunity, you know, in terms of capital, it would have really accelerated our growth. But we chose not to take it because of the change it would make to our identity and kind of the values of our business. And I'm really asking, it sounds like a great opportunity. It actually sounds like your leadership is willing to change the market for everyone. And I'm just really kind of asking this question to kind of challenge us all to maintain our leadership and our autonomy in respect for what our patients need, you know, and like push your executives to let you, if another hospital system wants to work with your direct primary care practice, even though it's funded by that system, if there's another system willing to facilitate better care for your patients, just kind of make sure you hold to those values, because I think they're important for us moving forward in kind of maintaining the values of our model. And the question is kind of how are there controls in place to help guarantee that moving forward, that it's not, you know, just a sole venture of that hospital?
Yeah, it's a great question. The short answer is that in the long run, there are probably no clear controls. Out of the gate, they've asked us and really given us the space to focus on the consumer, on the patient, in every decision that we make. So, and actually encourage us to kind of help then disrupt the internal part of the system by doing that. So there's nothing that makes me refer into the system versus refer out. I have the liberty to make that decision based on clinical judgment or the best opportunity for the patient. And so, as an example, by basically, let's take radiology referrals as an example. So we have an internal radiology group, and then there's a couple independent radiology groups in town. We helped the internal radiology group recognize that 75% of knee MRI referrals from physicians within the system were already going outside of the system because both the patient and the provider knew that the cost was notably better. And so as a result, then the internal radiology group has actually come to the table and said, wow, we've actually got to be more competitive. We've got to lower our cost. And so that's been kind of one example where that's played out nicely, and the ability that we're kind of able to help push the system to be better. I definitely have concerns, and I'm cautious about if let's say we're really successful and within the next 10 years we have 15 practices, and then all of those 15 practices are starting to divert things away from the mothership, whether or not there will be some pressure to not divert. But right now I haven't felt any of that, fortunately.
Who's ready for lunch? Guys, thank you for this.